Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we have a really cool discussion with a dentist, and I'm just going to leave it at that.
We are very pleased today to welcome Dr. Wanda Wright, who is the head of the Division of Dental Public Health and also the Assistant Dean for Diversity, Equity, Inclusion at the Department of Foundational Sciences and Division of Dental Public Health at the School of Dental Medicine at East Carolina University. Dr. Wright, did I get the titles right?
Yes.
Great.
You did.
So welcome to the podcast. And we're very excited to have you on to talk about your recent paper that you wrote with a number of co-authors on barriers to and facilitators of oral health among persons living with mental illness, a qualitative study. And thank you for breaking some ground on our podcast. You're our first, but hopefully not our last dentist who will be joining us. And I was actually thinking, just to start off our conversation, we can just sort of break down some of your titles. One is in dental public health. So I'm imagining a lot of our listeners aren't really familiar with what that is. So can you kind of give us a brief introduction to the field?
Okay. So first of all, I want to say that I'm happy to be here to discuss this very important topic. But dental public health is one of the 12 specialties in dentistry that's recognized by the American Dental Association. It's a specialty that looks at the prevention and promotion of oral diseases on a community-wide basis. It's a very small specialty. There are less than 200 dentists in the country that are board certified in dental public health. So we look at preventing oral diseases and promoting oral health.
Wow. So it sounds like a good fit for psychiatric services, just right off the bat. We were talking before we got on the line that your other role is in diversity, equity, and inclusion. We've talked on the podcast, particularly recently, about some of those issues in the field of psychiatry and mental health services. We can kind of imagine what that's like in other fields, but it'd be great to hear a little bit about what are some of the hot topics and what are the major issues around those issues, both in education, but also in the field of dentistry in terms of inequalities and inequities in dental health.
So some of the main issues are increasing access to care to underserved populations, addressing the profound disparities in oral health between different population groups, especially minority populations. Also, diversifying the oral health workforce. So trying to recruit and retain minority students. And so the dental profession is more diverse. So those are some of the main issues with diversity, equity.
Dr. Wright.
Yes.
I just have a question about that. My assumption is that when we talk about oral health and health promotion and prevention and the workforce, we're also we are including dentists, obviously. I'm assuming that there are other types of workers to which this applies, like technicians, or how do we think about the whole full workforce?
The oral health workforce, where we're talking about dental hygienists, dental assistants, mainly, like when I said dental public health, a small specialty, less than 200 dentists in the country, but there are a number of dentists who work in public health settings that are not necessarily board certified in dental public health. Mm-hmm. And, they are part of the large dental public health workforce, and they worked in, FQHCs and community health centers and that type of setting.
Okay.
And also nurses and physicians, they're also part of we consider them teachers, part of the oral health workforce.
Great. That's really interesting.
So we'd love to hear a little bit about how you came to this particular topic, and also talk a little bit maybe about collaboration that the paper involves. I know you have a really cross-disciplinary group of authors on here. So I'm interested in hearing how you personally came to the work, and then also how you gathered this interesting group of collaborators.
Okay, so my research interests are access to care for the underserved, also oral health disparities and oral health related quality of life. And the way this project came about was the psychiatrist on the paper, Dr. Anand. He actually contacted the dental school saying that he was concerned about the oral health of not just his patients, but psychiatric patients in general. And he wanted to collaborate. And so, we started talking and we talked about, let's first do a study looking at what are some of the barriers that these patients face in getting oral health care. So, so it started with the two of us. And then Dr. Lee, he's the public health expert. Dr. Lee and I had worked on projects before looking at tobacco cessation, in different settings and in the dental setting. And Dr. Lee also worked with Dr. Anand on different tobacco studies. And so, he joined our group. Dr. Benjamin is a medical doctor. She also worked with Dr. Anand and Dr. Lee on some research projects, and that's how she joined the group. And then I had a dental student. At the time, he was a first-year dental student, Jonathan Nowlin. He was doing a summer research project with me in our department. And so he joined the study. And then finally, we had a qualitative expert, Dr. Averett, who also joined. So it all came about by the psychiatrist, though, Dr. Anand. He initiated.
But the group of authors is also a real reflection of some of the things that you end up trying to address or talking about in the paper about cross-disciplinary work as being like one of the big things that can help. So let's take a step back and talk a little bit about what the specific research questions you were looking at, just a bit about your methods, what the sample was, and maybe start diving into a couple of key results that you found.
Okay, so the researcher question was, what are the barriers and facilitators to oral health among patients with mental illness? In our sample, it was a qualitative study. We did semi-structured interviews with psychiatrists or psychiatric residents, as well as dental faculty from the ECU School of Dental Medicine and patients who were diagnosed with mental illness who were receiving services from the outpatient psychiatric clinic. And so we ended up with 20 psychiatrists or residents, 20 patients, and 25 dental faculty members that we interviewed. So, we asked each of them a number of questions, related questions, like, for instance, for the patients, we asked them questions like, what has it been like going to the dentist? How important are your teeth for you? So what are some of the problems that you had going to the dentist? Have you had any barriers such as transportation, cost? Has fear been a reason? Have you ever felt judged by the dentist or their staff? Has time been an issue? What do you think have been the reasons you don't go to the dentist? We asked them about any experiences that they may have had with the dentist, whether it was good or bad, and what areas that they thought that we could help them with. And then we left it open. And was there anything else that they wanted to tell us about? So as far as the psychiatrists, we asked them, have they ever received any training in oral health for psychiatric patients? Do they screen their patients for oral health problems? Have any of their patients complained to them about any oral health problems? What advice do they give to their patients when their patients complain about oral health problems? And what are some of the barriers that they see that their patients are facing when they try to address any oral health concerns? Do they think that there is a connection between oral health and mental health disorders? And did they think that there is a higher occurrence of oral health problems among psychiatric patients? And if they did, what are some of the reasons for this? And as for the dentists, we asked the dentists how confident they were in providing dental treatment to individuals with mental illness. Have they ever encountered patients in their practice who had psychological problems? What type of measures did they take for the management of patients with psychological problems, such as, allowing extra time, contacting the physician or contacting the psychiatrist? Do they feel that there needs to be more communication between the providers? Do they think that the dentist skills need to be improved to help handle patients with psychological problems? Also, what are some of the barriers that they see that patients with mental illness face when trying to obtain dental care? Did they feel that oral health affects a patient's mental health? Did they think that there were a higher occurrence of oral health problems in patients with mental illness? And if so, what are some of the reasons for this? So those are the questions that we asked.
So you got a real comprehensive both sample of all the parties who are involved in the continuum of care here, and then really dug into all of the sort of issues that U-Haul, I'd assume, come up with as what you thought were going to be the barriers, and asked them for the responses. Were there any responses that stood out to you? I don't know if you have any offhand or any particular responses to the questions during the qualitative interviews that struck you.
That the patients did not feel judged in the dental office, but the physicians, the psychiatrists and the dentists thought that stigma was a barrier for these patients in receiving oral health care, but the patients didn't feel that way at all.
So does that mean that the psychiatrists and the dentists thought that patients wouldn't come because they were stigmatized? How do I understand that?
Yes. They thought that was one of the reasons why the patients didn't receive dental care, both the dentists and the psychiatrists, that they felt that they thought that the patients felt that they were being judged in the dental office, or that stigma was a reason. But the patients didn't feel that way at all. None of the patients that we spoke to.
It's interesting that it was more on the provider side, that there was concern about that than there was on the actual patient side.
And the psychiatrist, something else that stood up with the psychiatrists, more than one said that they refer their primary care patients to the dental school, but they've never referred patients from their psychiatry clinic to the dental school.
And then maybe you can just let us know how you all summarized some of your findings. You asked a lot of questions, you got a lot of responses back, and so what were some of kind of the key points that you want people to take home from the paper?
Well, some of the main barriers were the top two barriers were cost was the main barrier, and that's with most people. But the other barrier, second most common barrier, was the fear of dental care, fear of going to the dentist. But other barriers included things like the characteristics of mental illness, lack of screening by the psychiatrist. Transportation came up as a barrier also. But like I said, the top two were cost and fear.
And I think it would be helpful for our audience to hear a little bit about public sector funding for dental services, like what's covered under Medicaid, what's covered under Medicare, how big is the gap in services for people without those, where do people go?
So let's start with Medicare. Medicare is easy because Medicare generally does not provide any coverage for dental care. Medicare Part A and B, the only coverage they will provide is if someone is in the hospital and they may have a serious injury like an accident that affected the mouth, then they may provide coverage for that, but they do not provide any routine coverage for dental care. Medicare Part C might provide, and not all plans provide it, limited coverage. So in general, Medicare doesn't pay any routine dental visit. As far as Medicaid, it depends from state to state. A few states, Medicaid does not provide any dental coverage for adults at all. It's about 3 or 4 states that does not provide any care at all. Some states provide emergency care only. That means if a patient is in pain due to a dental problem or having an infection, they will cover that. Other states will provide limited care, and then other states will provide extensive care for dental. So it really depends on the state that you live in.
What's North Carolina?
North Carolina provides extensive care, which means prevention, restorative. They also provide dentures. But I believe in North Carolina, the dentures is one set of dentures every 10 years, something like that. But no orthodontic treatment for adults. And that's generally most states. Medicaid does not pay for orthodontists for adults.
And I think, as we were talking a little bit earlier, one of the things I took home from the paper was that this increased collaboration between the various disciplines is potentially key for increasing the availability of services, or having people actually referred from psychiatry into dentistry, or I assume the other way around as well. Do you have examples of integrated dental and mental health clinics or places where this is actually happening well?
I do not know of any integrated mental health and dental clinics. I do know that some of the dentists who have, while in dental school, have done a rotation, like on a psychiatric unit in the hospital. They do actually. They are the ones who they say feel very comfortable treating patients with mental illness. Some of the other dentists, not so much. But I don't know of any integrated, dental and mental health clinics. I
So
mean,
would you say that most dentists do not get any exposure to individuals with mental illness or to the field in their training?
there is training on mental illness, didactic training in most dental schools. I say in the first and second year, there are lectures on, these are the common mental health illnesses. This is the pathophysiology. This is the pharmacology. This is,
Mm-hmm.
how we should treat them, in the dental chair. And then, but that's pretty much it. I mean, and once the students get into clinic, it really is primarily observing how the faculty member in the clinic handles the patients with mental illness. It's not really integrated. It needs to be more integrated and more visible in the curriculum and integrated through, all 4 years of the curriculum. So while the students get some, it's not nearly enough. And, they get it the first couple of years. And then once they get into the clinic, they're kind of on their own, how they handle the patients.
Do they learn about, for example, the potential impact of psychotropic medications on oral health?
Yes. Yes. Yeah, they do learn that. Yes.
I mean, it was fascinating reading the paper because as I was going along, I was just thinking through the patients that I've cared for, and it's just something that has probably crossed my mind from time to time, but I haven't really kind of consolidated it. That it comes up all the time. Dentistry issues is like really, really constant. I just thought of like 3 or 4 people who I had seen in the past like couple of weeks, just off the top of my head, who had dental issues, and so it was a bit of a light bulb moment for me to just think, wow, and I have no idea where to refer people. It's like I don't. It's just not part of what I think of as my scope of practice, but it should be, right? My own experience has been that the population has a lot of dental issues.
No, that is true. I think the psychiatric patients who are hospitalized they do receive dental care. I mean, but with more patients living in the community, I mean, those are the patients who are falling in the cracks.
When people are admitted to hospitals and have dentistry issues, is there a kind of bias towards extraction? It seems like my experience was that when people were inpatient and they would go for dentistry issues, they would say we need to pull like a lot of teeth. What seemed to me like a lot of teeth. I don't know if it would have been different in the community or not. And maybe that's just a function of people's not having received dental care for years and years and years. But what is it like do you know what it's like on the inpatient psychiatric side when people do get dentistry there?
I don't know if there's a bias for extractions. It does occur often, but a lot of times it's what the patient requests. And sometimes it's if they have insurance, what the insurance is going to cover. So paying $150 for an extraction versus, $2,000, for the root canal, and, another couple of $1,000s for a crown, to put on their tooth. Many people.
So that really speaks to the quality of the care that, not that it's necessarily anyone's fault, but faced with $150 bill versus a $4,000 bill.
Exactly.
I also was interested in the discrepancies or the differences between the groups. And another one that I picked up, 2 items that were endorsed by the psychiatrists and the dentists, but not the patients, were 1, perceived lack of interest in preventing dental disease. And the second one was perceived lack of support from family members. So the psychiatrists and the dentists seem to think that the patients perhaps lacked interest.
Right.
Patients didn't report lacking interest. And I just sometimes I think that's really that's stigma, on our part, on the part of providers, perhaps, of attributing lack of interest to the patients when they don't seem to endorse that.
And sometimes that dictates the type of care that they receive. I mean, if the psychiatrists are perceiving lack of interest, they may not refer. And then if the dentists are perceiving lack of interest or lack of family support, they may or may not get, the type of care that they deserve to get.
I wanted to also pick on something that Josh said, because I think every mental health provider who's listening to this podcast and who read your article will be able to will resonate with this problem and challenge. And what Josh said, it is something that I've experienced too, which is, where do you refer people?
Yes.
How do you address this? And it just seems to me that it may be very challenging to arrive at solutions, particularly where there's no Medicaid coverage.
Yes. Yeah, it's very challenging to, how to improve the oral health of this population. If there are no resources in the community, and that's common, where there's providers are not, there's many providers, even if the patients do have Medicaid, there are many providers who don't take Medicaid insurance. If there's no community health center with a dental component there, or there's no dental school around, I mean, that it's a big problem. Where do the providers, refer the patients? And, that's the big issue.
Is this a problem for all people who are poor?
Yes.
And do you think it's worse for people with mental illness? Or is it sort of part of the larger problem of access?
I think it's part of the larger problem with access. It might be, when you say worse for, people with mental illness have more risk factors for poor oral health. And so they're likely to have more unmet dental need. And then if they don't have anywhere to go, so that makes it, and then, and then the association between mental health and oral health, how one affects the other.
Right.
And so, so in some aspects, it could be worse. But even in children, like Medicaid in children, all states, I believe all of them, provide dental services for kids. But at the same time, many pediatric dentists or general dentists don't take Medicaid. So even with that insurance, there's a big problem with access to care for those kids. To even have a preventive dental visit in a year, the numbers are right, less than 50% of kids with Medicaid had a preventive dental visit. So, even having the insurance, doesn't increase access.
If you had a magic wand and could fix one aspect of policy around this area, what would be your first step?
Probably more dentists who are taking Medicaid, and I think that would be in more adults who have Medicaid dental benefits and that can use it. It's one thing to have it, like I said. I mean, there's every kid with Medicaid have the dental benefits, but they can't use it. So, what good is it?
And one other magic wand question: as long as you have a captive audience of mental health providers, is there anything that you think that we should know as mental health providers about oral health in general, or particularly around this paper?
I think that dental diseases are almost 100% preventable. And even so, the poor oral health in patients with psychiatric illnesses are a significant public health problem. And that, there is the association between oral health and mental health. One affects the other. So the question is, who is responsible for improving the oral health of these patients? And I think it's a joint responsibility between the dentist and the psychiatrists or the mental health providers to work to improve the oral health of this population. And the psychiatrists, there's simple things that they can do. One is to we talked about the resources in the community, and just to try and determine what are the resources, if any, in the community where these patients can be referred, but also asking the patients about, their side effects of the medications that they're taking, and asking if are they experiencing dry mouth, are they having difficulty, swallowing dry food, are they dry lips, are the lips cracked or whatever, and then recommend a salivary substitute or stimulant, or recommend that they chew sugarless gum or gum with xylitol in it. They can also educate their patients about how to maintain their oral health. The patients in our study says they look for their psychiatrist, they listen to them, and they want their psychiatrist to tell them about their oral health, or, you need to go to the dentist. And so just, basic small things like that will help improving the oral health of these patients.
That's so great. Thank you. So let's say we want to have you back next year. And if you had all the money in the world, well, if you had an opportunity to do the next phase of your research, what would you do? And I know, of course, funding is very difficult, but I'm so impressed by this work. I hope that there's going to be a phase 2.
So we looked at their oral health status. In addition to doing the qualitative part, we also did a quantitative part. We looked at their oral health related quality of life. We also looked at their oral health status. We looked at 100 patients with mental illness and did a clinical exam, screening exam on them, and assess their oral health related quality of life. The long-term goal is to develop some strategies or interventions to improve the oral health of the population. So, but the step that we're working on now is to, we're analyzing the data as far as their, the oral health related quality of life in this population.
Well, we certainly look forward to having you back on and hearing more about the next step in the research. And we want to thank you for coming on. Hopefully, this will be an example for people, the type of collaboration that will improve some of the oral health issues of the population. It's a much needed topic, and we really thank you for bringing it to our attention and coming on and sharing all of your wisdom in that area. So, Dr. Wanda Wright, thank you so much.
Well, thank you for having me.
I can't wait to have her back because I think this issue is so important. Well, that's it. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. We also, of course, welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berzin.
Thank you for listening. We'll talk to you next time.